Welcome back to another episode of the Brawn Body Health and Fitness Podcast. Joining me today is Jeremy Aspa. Jeremy is an athletic trainer and strength coach for Rude Rock Strength and Conditioning. And Jeremy and I are going to be discussing some of his various past injuries and how he's helped rehab himself and how he applies what he has learned and how he's rehabbed himself to the people that he works with day in and day out. Really great episode from one of the absolute GOATs, especially as it comes to thinking through a fascia lens. I highly recommend you check out everything Jeremy is doing online. This season of the podcast is sponsored by Isophit. Isophit is my go-to for everything related to isometric strength training. For more on Isophit, you can check the description below. Enjoy. Jeremy, welcome to the podcast. I'm super excited to finally have you on here, man. Thank you so much for being here.
Dude, thank you, man. I'm super stoked to chat it up.
For people who maybe haven't heard of you and all the incredible things that you do and your abundance of free time, dude, would you mind filling them in a little bit about who you are and what you do?
Yeah, so I'm Jeremy. By trade, I am an athletic trainer, ATC. Most of my experience has been in the college setting, except now kind of went away from that, and now I'm in the military setting working with fighter pilots.
A really cool thing. And you also have a role in Rude Rock as well, I believe, correct?
Oh, yes. And I'm also like one of the strength coaches, like restorative based, fascial based kind of strength coaches for Rude Rock Strength and Conditioning. So look that up. We got a wealth of knowledge from the whole team.
Yeah, we'll definitely have to link to Fascia Chronicles. I know we were talking about that earlier and all the amazing stuff that you guys do that way, because I love the kind of stuff you guys are putting out regularly. And I really like the way your head works when it comes to exercise and rehab and that sort of thing. And I'm excited to dive into all of that. But, we literally just spent like 40 minutes talking about all kinds of crazy stuff. And I feel like we got to at least visit some of that. We've talked about a lot of random things on the podcast with people, from like cheese to true crime to like actual rehab and strength and conditioning stuff. But, at least for me, I've never brought up like the topic of like aliens for anyone before. Do you have like anything to offer us in the world of, are aliens real, and like what exactly have we been visited by ET? Do you feel like the aliens built the pyramids? Like, give me a rundown here, Jeremy.
Rundown? I don't know, man. Like it's I'm almost scared to talk about that. The only thing I'll say is this: I have heard that the FBI has investigated Bigfoot, so that's all I'm going to say.
Oh my goodness!
At least that's what the interwebs tells me.
That's what the Wikipedia tells you.
Yeah, and the history
Gotcha.
and the history channel.
Oh my goodness. Yeah, no. And I feel like we could probably just do a whole podcast at some point about conspiracy theories. In fact, we might just have to put that in the works here. I don't know if anyone would listen to it, but it would be real fun for us.
I might know a couple old guys, I will not name, but yeah.
But, as I was alluding to, I feel like every time I've talked with you or every time I've seen you, something new has been injured or tweaked, whether it's your Achilles or your elbow. It seems like something's always going on.
Yeah.
What's your take on that? Have you just had some real like shit luck, or like what's going on, Jeremy?
A lot of shit luck. That's a testament to how much of an athlete I am not. But yeah, I mean, I've been cursed with a lot of injury, especially some that I'm going through now. But the blessing in that is experimentation on myself in terms of my own treatment and rehab, and bringing that to what I do to treat like my patients. Or even if I'm coaching, it's a good way to recognize how to modify something, or modify something that I still need a certain adaptation for. So the experimentation lies still with my coaching and patient care.
Right. You get to literally try everything on yourself,
Right.
giving you more of a feel of what it is you're trying to do from an exercise or intervention, what you're trying to feel, how to coach it, different cues, and so on that way. And I certainly feel like that gives you a leg up
Yeah.
Walk me through that kind of personal injury history. Have you always been like a injury prone individual growing up, or has it just been the last 3 years? Or
Yeah, I no, I growing up, I always got hurt. Like I love being active, but there was a point in time when, growing up as a kid, I would get hurt like once a year, like a really big injury. um, I'm glad that kind of changed, but yeah, I've always seemed to get hurt just because either stupid stuff or really trying to like chase numbers in the weight room or just having bad luck. But again, looking back at it, um, it was still a good way to really like sit down, reflect, and opening a notebook and trying to write down things I should have done, things that I could have done, um, and pretty much mock like cases of like, what if this happens to someone else that I could apply to that actually worked on me? Not saying the things that worked on me would work for someone else, but it's a good start to getting the gears rolling on how to treat.
yeah, I love that concept of actually having some self-reflection because I think that's something I see missing for a lot of clinicians, right?
Right,
We get our patients in, we treat them, we do our notes, we do our thing, we discharge them, and then we never really look back and reflect on it and think, what could I have done better? What could I have done differently?
right,
And not only do we not do it for our patients, but to your point, I don't do it for myself. Like, I don't look back at what I was doing in training a year ago. In fact, lately I'm not even tracking my own training. I'm just going up to the gym and it's like a free for all. It's like, you know what, today, I know it's the third day in the row, but we're going to hit back and buys because, we just need a sick pump. So I certainly think that there's a lot of value in what you just said in the tracking of things and actually being able to look back and reflect and understand, did we get the response we wanted? And if we didn't, then why did we not?
right. It's just taking your own advice. It's kind of based off the premise of, would you give your athletes or patients something that you would do? Like kind of, that thing.
Yeah, no, definitely. And the other thing I like too is you mentioned that you had faced a lot of injuries growing up and you're still facing injuries, but that doesn't stop you from doing things. There's a lot of individuals I've met where, they get hurt once or they get hurt twice and all of a sudden they give up on everything. They don't want to weight lift, they don't want to go to the gym, they don't want to, play organized sports or even like any kind of sporting activity because they're afraid of getting hurt again. And I
Right.
think that's a real slippery slope that we need to try and, find ways to nip early on because, plain and simple exercise, movement, sport, it's good. Yeah,
Right.
there's a chance of injury, but there's a chance of injury with everything.
I
So
mean,
I would rather
it's
find,
dangerous with driving, like you can't be scared of what hasn't happened yet. It's just not a life worth living, you know?
yeah, no, definitely. And I certainly think that, in today's day and age, it would be better for us to kind of frame the conversation of, yes, you've gotten injured, but we can get you back to sport and we can do things to help make sure this won't happen again. That's not to say something else might not happen or that's not to say some freak thing won't happen, but I certainly think that we have evolved so much from our understanding of injury from a rehab and strength standpoint where we can push the envelope a lot more and get people back a lot better than they were before and hopefully mitigate that risk of re-injury.
Kind of going back to that, a lot of it too, it's almost from a cognitive mental health standpoint, like training to prevent injury or training to heal an injury or waiting while you're healing an injury. It's all, I think, um, like we have to change the mindset and attitude of how we view the weight room, how we view working out, how we view just human performance in general. Because as we're progressing through this whole field of human performance, there's so much things that are starting to pop up that are like, oh my gosh, like I'm gonna try it. But then there's also still the camp of just still doing like bodybuilding or powerlifting workouts for sport athletes. I mean, it's a huge injury in sports is already a huge public health epidemic issue. But then if you look at it from a youth athlete standpoint as well, I mean, it's, the numbers are going up every year of how many like adolescent youth athletes are going just to a hospital visit because of like traumatic events or just overuse injuries. Like, for example, like female cross country. I mean, that's one of the highest rated youth sports that have a lot of chronic injuries. So, you know, what are we doing to educate folks on how we attack the weight room kind of thing, you know?
Yeah, no, definitely. And that was something I think you just spoke on something similar to that like a week or two ago at a event with Tim Kelly, correct?
Yep, for sure. Yeah, we threw on like a local performance clinic geared towards, high school, college athletes, position coaches, and parents.
I guess I gotta wonder too. You kind of mentioned that everything exists on a continuum here. On one hand, you've got your like barbell junkies, bench squat, deadlift, Olympic weightlifting, all that sort of thing for every athlete. And on the other hand, you've got maybe more of like a, GPP, I'm gonna throw a lot of different things at them, just build a better mover kind of thing. Where do you kind of sit in that camp for yourself, and how do you kind of transition that into your rehabs? Are you a pretty barbell heavy guy yourself? How do you approach your own training and rehab that way? And how does that carry over to the patients that you work with?
Yeah, I think a where I'm at on that continuum, it just changes based off of who I'm working with. So, sometimes I'm super barbell heavy, sometimes I am super movement heavy, uh, and just kind of everywhere in between. But I think my non-negotiables are um making sure I'm looking through stuff through a fascial lens, movement quality is always there, and like a neuromuscular education coordination kind of standpoint. Like those all have to be the non-negotiables, whether it be you're doing Olympic weightlifting, you are training for sport, you are rehabbing from injury, even if you're kind of in like a higher, older population. So anything, no matter who I'm training or treating, I make sure those qualities are there. I mean, because a lot of times, strength is an issue, movement's the issue, uh, neuromuscular inhibition could be an issue from like pain generation standpoint. And again, it could vary in complexity if there's something more sinister going on in the system, if there's actual mechanical damage to a joint going on, or even, getting your differential diagnoses of, this might be a systemic issue that's out of my realm and needs a referral somewhere else.
Yeah, no, right. I think you brought up so many great points there, Jeremy, as you were talking. And one of the things you mentioned that you're always looking through a fascial lens when you're coaching, when you're rehabbing, and that sort of thing. What exactly do you mean by that? Does that mean you're kind of thinking in terms of fascial lines instead of how we typically learn anatomy from like muscle origin insertion? Or what exactly does a fascial based approach look like for you?
So, I mean, that's kind of almost what we've at Root Rock Strength have evolved into is just uh fascial mechanics, treating the fascial system uh not only as an extension of the weight room or sport, but that's kind of the premise of body movement. So if we just kind of step back and then look at fascia, I mean, we're defining it. There's so many definitions, but I mean, you could define it as like um the global connective tissue that kind of really seeps in and intersects like all aspects of our body in soft tissue. So that gives us our dynamic kind of expression, that gives us like our sensory motor kind of like feedback to elicit these like efferent expressions, I guess. And it gives us like our scaffolding in the body. It allows for, information transmission, it all this stuff where like movement based and information and sensory based, which again, if we talk fascia, it's such a vast complex of things going on at the same time that just gives us our movement, if that makes sense.
Yeah, it
uh,
does. It does. I mean, in general, fascia being just a global connective tissue throughout the entire body, as you mentioned, it has very essential but often overlooked, in my opinion, roles from a neuromechanical, neuromuscular side of things, from anything as simple to just overall proprioceptive input to the body to actual transmission of force, right? I mean, we think about the basic posterior oblique sling, probably my, main go-to when I'm working with people, because it's connecting glute max and contralateral lat, which is essential for rotational power and rotational development. But everyone seems to forget that right in between those two is the thoracolumbar fascia, which is where that force gets transmitted from glute to lat,
Mm.
or lat to glute, I guess. So with that said, it's like, that thing in the middle is being overlooked and forgotten by pretty much everyone. Yet that thing in the middle could be right where we need to right where we need to intervene, exactly what we need to address. But like, that's not unique to just that system. That's unique throughout the entire body. There's fascia literally everywhere, not just in the spine.
Right. And it's being it's getting more visibility, I think, because I always think of it like how you and I probably through ATPT school, or just when people in human performance learn about anatomy in general, fascia is not just a packaging now for our skeletal muscles. There's a fluid component, there's a structural component, and like a sensory component to it. So it's not just, holding muscles in place just to give it shape. There's a functional and, even healing component to it. So
Yeah, no, it's exactly. And on that fluid piece as well, on fluid dynamics, I mean, plain and simple, you probably get some people that come to see you because they're in pain.
yeah.
And I think every time, at least when I came out of school, every time I was getting someone who was coming in to see me because something hurt, I was thinking, well, it's got to be mechanical, right? I've got to pick apart something from a movement standpoint that explains why this hurts.
Right.
And we kind of forget about the chemical side of things, right? The fluid side of things, right? Like, there's certain areas of the body that they just become inflamed, irritated, and pissed off. And guess what? You get these inflammatory cytokines and other painful things that build up there and they don't go away. It's going to stay hot. It's going to hurt. And you're not going to get anywhere unless you address that underlying chemical issue. We always talk about root cause and underlying issue, and we always think about that being a movement thing. And sometimes it is, but sometimes it's other underlying factors that we often forget about.
Yeah. I mean, not to say that, like you can correct someone that just completely tore their ACL with fascia stuff because like clinically your ACL is torn. But I mean, from a fascial lens, now that your ACL is torn, you've lost this proprioceptive ability and this mechanical stability to operate at high functioning athletic speeds of the game. I mean, sure, that is a mechanical uh, thing going on, but then it's not just that. It's like, how do we address fascial stuff in the rehab once the ACL is reconstructed? Or, you have these fascial considerations based off the graft the surgeon's using, which could be a whole nother podcast topic for sure. But again, that's the beauty of fascia. It's this global response to everything: your training, your rehab, your prehab, your post-operative care. Fascia is just not a singular system that you're just looking at. Because I mean, every time I talk to someone and they're really like super not subscribed to the word, even like it's almost threatening to them when they hear fascia or fascia mechanics, it's literally not something we're doing different. I mean, it's pretty much giving you another understanding of why you're doing things. Because like the fascia has healing components that you can probably make better educational like inferences or decisions on what modalities or methodologies you want to do in terms of treatment, in terms of the weightlifting piece, in terms of the athletic development piece. It just gives you a better understanding of what you should probably do first or make a priority than completely changing your methodologies. You know what I mean?
Yeah, exactly. You have an underlying like set of principles that you use to look at things.
Exactly.
Um, yeah, I think that's an essential piece. And to that as well, you mentioned a little bit ago about neuromuscular control and how that's one of the things that you look for and how you intervene from a therapeutic standpoint, but also how you go about coaching. And I've seen you coach before where that kind of impacts your cueing too, especially in the Olympic weightlifting side of things. And this is another area that I see a lot of debate, right? Is neuromuscular control the reason for our injury, or, is it something else? Because we see people move into valgus all the time. They don't tear their ACL every time.
Right.
But by the same token, it's also like, well, there's a lot of non-contact ACL tears that happen from that valgus moment. So it kind of becomes the question of, where do we draw the line on neuromuscular control, And at least for me, I haven't found like the one best answer for that yet. I've got a lot of different theories about it,
Yeah.
but I don't think that we really have the best answer as far as neuromuscular motor control and overall injury that way. And, I've looked at some of my past injuries that way, and there's been times where, I hurt myself and I look at the form and I look at the mechanics. I'm like, oh, yeah, I can certainly see how that would happen based on how I was set up. And then
Right.
there's other times I look at it and I'm like, no, this looks perfect for, this. And I don't see how things could go wrong. So I certainly think it's one of those things where there's not really one best answer for it yet.
Right. Yeah. And I don't have that answer either. Which I think in terms of neuromuscular control, again, it's another property that the fascial system could give you. And all these properties are overlapping each other. It's not like a rehab protocol where you have to do this before you can do this, before you can do this, or enter all these phases of rehab. It's how can you train certain properties again on this continuum. You just might be moving on the continuum in a different way, or you're shifting that continuum based off that treatment day. With neuromuscular control, um, I think it's something that you still have to, it's important for sure. But then if we're talking about like non-contact ACLs, I still think there's a lot of good credibility in terms of still your anatomical like predispositions, how like the whole Q angle thing, or what your femoral like the notch might look like if you have a notch that's more predisposed to like those shearing forces with certain movements in the ACL, like that we can't change if that's a bony anatomical issue. But then it's something that's still trainable, because again, if you take these like elastic, plastic, sensory motor kind of properties, that's still all trainable to hopefully prevent something, or being able to train someone that can handle again like game speed well.
Yeah, and sometimes I've found, at least in my opinion, I feel like, maybe the movement fault is there, and
Mhm.
maybe we can handle a few of them without issue. But
Right.
sometimes it's the load, too much of or not enough of, that really seems to overdo it for people, right? Like a lot of times when I'm seeing a lot of ACL injuries, or even like you had mentioned before, you had some tendinous issues in the elbow and the ankle Achilles there. And it's
Mhm.
one of those things where sometimes it's the mechanics are good, but we've overloaded the tissue too much, or maybe the mechanics aren't good, and now the tissue is trying to, use some kind of compensatory mechanism and it's getting pissed off because of that.
Yeah, for sure. I mean, I think that goes back to like the coach's eye or the clinician's eye. Um, because load intensity, magnitude, frequency, training density, that all matters for sure. But then again, what we didn't mention there is the recovery dynamic of the tissue. I mean, movement and training and play break down the body, but then as much as we're playing, we have to like consider we have to recover just as hard as training.
What exactly does recovery look like for you, Jeremy? Like, how have you implemented like these recovery strategies for your elbow, your ankle? What kind of things do you reach for?
In terms of like injury, I mean, I reach for a lot of just low level passive modalities or stuff that I don't have to like move. I mean, I think that's a good start for like an active recovery. So like the band flossing, it could be electric stimulation stuff, like with power dots and stuff like that. The Normatec recovery systems are super popular. I think BFR is starting to get some traction with recovery. So things like that, I think that's a good start. And then low hanging fruit here is like the breathing stuff, like down regulation of our central nervous system, things like that. Even, dry needling, I do that a lot, even just on myself. Shout out to my coworkers that I'm always like nagging on to, like treat me, quote unquote. But it's stuff like that, or even, the cold tub stuff. And all research aside, I'm just kind of naming off stuff we can do, like the sauna, the cold tub, sensory deprivation. Like that's all stuff that we don't have to pretty much think about, at least on an elementary level. But it starts with that, and then another piece that's overlooked is if you're not eating enough, if you're not eating enough nutrient density stuff, obviously that comes into play. I mean, if you don't have a gas tank, you could think you're working hard, but really you just don't have no fuel in the tank. Um, Even from a mental standpoint, all the, a cognitive based approach to just recovery in terms of if your body's tired, train your mind kind of thing. So a lot of even soft tissue work. So that could be another active kind of passive recovery, to kind of blend everything in this umbrella of human performance.
Yeah, no, I like that a lot. And, I think it's one of those things where, I definitely bash on modalities a fair amount, in particular pulsed ultrasound.
Yeah,
And I'm very thankful that you didn't name that, Jeremy.
I
Because I still have
might hate what I have to say next then.
I've yet to feel the effects of that, but maybe it's just me. But I think that all the things that you mentioned do have a time and a place. It's just a
Yep,
matter of understanding what they're good for and what we use them for. And I think that's an area a lot of clinicians are disconnected from, right? Like it's so
sure.
easy to slap heat and ice at someone or, cold plunge or whatever that way and just kind of say, this is our blanket thing. Everyone's going to do it, but it's like, is that exactly what that person needs? And it's more about matching right intervention for the right person at the right time. You mentioned needling, great tool to improve tissue quality, but
Right.
is that what that person needs? Can the person even tolerate needles? Because some
Exactly.
people have looked at me and said, look, I'd pass out if you tried that. So,
Well, I think so. I mean, I'll partly disagree with you. Like it, I based off what I respond to with my own injuries. I mean, like what you said, there's a time and a place.
yep,
The time might be literally you have no time to do this stuff because in your, line of work, you're probably not seeing them every single day,
right.
which on the AT side of the house, we're literally seeing them every day, even
Hmm.
on a day that they're not playing a game, even if they have like a complete off day. Like in football, usually our complete off days were Mondays where they just had meetings and stuff like that. And then like a optional weight training kind of lift. But I think that's where all the passive stuff, where all the clinicians are starting to shit on like stuff like the ultrasound. I think there's still great benefit to it, but then again, the time and a place, that's where time is in consideration. So if you're doing a heated, like thermal ultrasound treatment, usually the machines that we use start off at the 5 minute mark. And if you have a big area that you need to really heat up, that 5 minutes at a 2.0, that's not even going to start heating anything up. I mean, we're talking like 15-minute treatments on an ultrasound, which might not be the best thing to do when you have like a 20 patient, like caseload that day. Because that's right there. That's almost half the treatment session. Um, I could see how that's not the most viable option. And again, research aside, we're probably seeing all this research now that doesn't support anything. But then in the event that we're trying to really um, prevent surgical cases, if we're trying to really hone in on the conservative treatments of things, especially like tendinopathy, I think it's all time based as well. Because again, this isn't me supporting anything. I just want to get that out of the way. But it's all time based. Like there's a certain like level and frequency and you know, um, the hertz that you have to, it's time based to heat something up or to reach a certain level of the tissue. Like that's basically modalities 101, you know.
Yeah. Yeah.
Um, so again, time and a place, you're exactly right. But I mean, from a theories perspective, I think there's a lot of benefit to those passive modalities, especially in the case of like injuries where there's a lot of you're at those like end stages of a lot of degeneration. I mean, sometimes movement isn't the best option all the time because I think, in my opinion, you have to get a certain level of healing before you could load appropriately.
Yeah, and I think the piece that you bring up here too on the time component and that sort of thing, and even just the overall effectiveness component, right? Like, as you mentioned, there's a lot of people criticizing modalities, and I'm very guilty of that myself. But the other piece too is, we look at research and we need objective markers from a research standpoint in order to track things, improve things, and that sort of thing. And I feel like a lot of the times the benefit we see from modalities is subjective, not objective.
Right.
I might do this thing to this, soft tissue area, but I'm not gonna see like, a 30% strength gain just because I did some modality. I'm not gonna see a huge, sweeping change in range of motion. But if people tell me they feel better afterwards, then that's effective, isn't it? So it kind of becomes a conversation of, we're using it as a way to treat and make people feel better than they were before. And if that opens up a window for them to do some movement or do something else, then, we kind of have to be all for it at the end of the day. It's just a matter of understanding what it's doing and what the impact is going to be because of it.
Well, that's the thing. It's the understanding of what you're doing it for. With the passive modalities, I think of it as like almost pain management. You have to have the patient or athlete kind of find that entryway into the Therex and the working out piece or training, and them doing that with pain, it doesn't, to me, that's not right. Like, sure, we have to load tissues. That's almost like a must, but it's at the expense of, are you creating more damage or are you helping like repair the damage, so to speak? For example, like I might get a lot of heat for what I'm about to say, but like the whole steroids and injections, I think there's a time and place. I know that's starting to people are trying not to push that, but depending upon like what you're injecting or what you're taking, these steroids for, I think there's a time and place for it.
Yeah, and I mean, I know that's a very debated one as well. And to that point, I don't endorse it and tell my patients to go do it. I'm not that guy.
Yeah.
Um, but there's times in the past where patients have actually asked me questions about it because everyone's curious. And everyone wants to know what can they do to get that edge coming back. And if they can optimize their internal physiology from a hormonal standpoint and
Yeah.
protein synthesis rate, that certainly helps. But to that point as well, then to me it becomes a matter of what other boxes, what other low-hanging fruit could we check?
Right.
Because I'd prefer to not have someone make that exchange and deal with the devil and do those things, that, like I said, that's not anything I endorse, and that's, to the best of my knowledge, none of my patients have done that, that I know of. With that said, it's like, what other things could we do before we get to that point, right? Could we try creatine mono? Could we try some red light therapy? Could we try, hyperbaric oxygen or cryotherapy, or like looking at all the other options that we could do to achieve benefit and gain, but aren't as intrusive as that.
Yeah, and I don't endorse that either on the steroid side, but again, time and a place. I think when you're talking about like the steroid injections to really kill like every inflammatory thing going on at a certain injury site, usually people don't understand that they need to take a pretty significant rest so that the medication, I guess you could say, doesn't actually bite them in the butt later. I think that's what makes it a super negative kind of connotation. Like they obviously they want to get it for a super short term relief and then just go back at 100% like the next week or even the next 2 days. Um, in my personal experience, I mean, when I had it done in my elbow, again, this is not medical advice. This is just my own decision of wanting to get it. I mean, I took like from like Muay Thai, I took like 4 months off to really, all right, my pain is gone. I need to really slowly ramp this up so I could actually put my tissues in a position of healing. Cause I mean, the steroids are super like invasive on everything it touches, even on the healing mechanisms. So I was like, I got to make sure that I'm putting my joint in a good healing, like roadmap so I don't screw myself up because of this injection. And all that to say, I'm not endorsing this at all. I would rather much have someone do extremely non-invasive treatment. But again, to that, you have to realize with stuff like tendinopathy, it takes a long time sometimes, depending upon what stage of that tendinopathy continuum you're on, because it's kind of like almost a disservice where you try to do stuff for 3 months super conservatively, things aren't really getting that much better, and then now someone's suggesting surgery. Like 3 months to me is not a it's a long window, but in terms of healing with super chronic injury, it is not that's not a long window at all to me.
Yeah, and I could be wrong about this, but I don't think that surgical management of tendon injuries, in particular, not the full ruptures like tendinopathy or partial tears, I personally have not seen the best outcomes from that. And maybe it's just a me personally thing. I haven't, done a deep dive into the research on that. But in general, I mean, we don't even study tendons with biopsies anymore
Yeah.
because of how painful it was for people for like 18 months after the studies. So from my standpoint, I kind of look at that and say, like, look, tendons are very difficult. They're very, involved that way. And to your point, there are times where we really need to let them cool off. And then there's other times where we really need to load the sucker because I feel like tendons really love load. And I think understanding, to your point on the steroid side of things, that could be something that really does some detrimental things to tendons in particular.
100%. Yeah.
So this is a area where I would highly encourage isometric loading in particular. I feel like I can generally find a starting spot for everyone from
Yeah.
an ISO standpoint that is pain-free for them and gets them some kind of benefit, whether that's just improved range of motion, less pain. There's something good that comes from ISO loading. And I could say that about pretty much any tendon from cuffs to quad patellar to Achilles and so on that way. I feel like ISO loading in particular tends to do well. And then I usually follow that with some eccentric work later on, but I almost always go right for the ISOs from the start. And I keep doing that just because people freaking love it and they do well with it.
I mean, some of the, you know, for tendinopathy, it's like a lot of the cells in like the cellular matrix, like tenocytes, they are extremely receptive to mechanical movement and load. Like that's how they just operate to, for collagen turnover to help give what that damaged tendon needs. So I mean, you're right. Like I think we have to load folks who have tendinopathy. But then again, I think with tendinopathy, it's a super complex issue that we're oversimplifying sometimes because sometimes you cannot load because of the pain. And it kind of boggles my mind where everyone's just like, oh, like tendinopathy, you have to load. Well, what if you can't? So that's where the complexity starts within this continuum, because with tendinopathy, I think that um you have to tailor your treatments and your training based off of what's going um on that continuum, whether you're more in the okay phase or the extreme disrepair phase, uh, and then tailor it to that so you can kind of move towards the green line of that continuum versus staying forever in this like red line.
Yeah, and not to mention just making sure that it is a true tendinopathy,
Right.
because a lot of times, and I think this might have been the case even with your Achilles, I can't remember, where we diagnose things as a tendinopathy, but in reality it's something else. Hey, maybe we're getting like some fat pad impingement in the knee, or maybe we're getting like a bursa kind of thing, like retrocalcaneal bursa or something along those lines. Like there's so many other things that can be comparable to tendinopathy in a similar region anatomically. It's just a matter of, do we look deep enough to actually differentiate those things? Because we might change our rehab approach and the underlying principles based on the tissue involved. And if we're rehabbing the wrong tissue, then our
Yeah.
approach might not be working and it might be flawed from its underlying philosophical standpoint.
Yeah, I mean, that you're completely right too. Like that's where the clinical diagnosis piece has to be pretty good. So we could accurately treat or train who we're working with. In the case with my Achilles, I mean, it was so bad that I had to be in a boot for like, 5 to 6 weeks before I could start initiating more sophisticated stuff. You remember that? I mean, I kind of posted that stuff on my socials, but that's kind of like a good example where let's not load it just yet. I feel better, you know, immobilizing it to give. I think there's still benefit to complete rest. You have to give that Achilles, and especially where mine was like right at the insertion point too, like that there's a lot of stress right at that point, and insertional, tendinopathies to me are extremely painful for movement, because I think no matter how you move it, even if you're in dorsiflexion, you're getting a lot of compressive uh you know like forces right at that insertion point.
Yeah, no, definitely. And I think if I remember correctly, you did a little bit of work on my favorite thing, the Alter G, as well to come back from that, correct?
Yeah, I mean, like another great tool to have. I mean, not a lot of places have that, but it's starting to, show up in a lot of like PT clinics. Like it's a great way to just get movement without the full body weight, obviously. I mean, that's what it does. But again, you could still train movement and how you're supposed to move. I mean, I felt pretty good at only like a 50% body weight doing a bunch of stuff that I can't do full body weight when I was like healing up from that. So again, yeah, another great tool.
Yeah. And, maybe you're someone who, like me, looks at the price tag and you're like, there is no way I'm
Yeah,
spending that.
right.
In which case, I actually found that resistance bands hung
Yep.
up high on a power rack work
Yep,
just as well to unweight people.
for sure.
In fact, I almost used that for pretty much every Achilles post Achilles tendon repair. If someone ruptures the tendon, I'd start them with a certain band for heel raises, and then we progress the band resistance down over time, because I can look up online and get a chart and know how much weight that's pulling based on how long the band is. So I can say, hey, look, I'm unweighting, 60 pounds here. Now I'm unweighting 40. Now I'm unweighting 20, and get that similar kind of effect in a much more cost effective and space saving, approach that way. And I like the fact that, with something like that, I can actually like send people home with it. I can say, hey, look, these bands are 15 bucks on Amazon,
Mhm.
go do it at home. I certainly think that there's a time and a place to change your approach from a loading standpoint, not just in the add more, but maybe even take off weight or reduce your load And even sometimes that's even reducing below body weight, as we were talking about there. And, there's certainly a time and a place for everything. It's just a matter of, again, right thing, right person, right time. And if you don't get that, then you end up wasting a lot of time. You make everyone kind of frustrated, and it's just a really sticky situation to find yourself in.
Well, I think to what you said, I mean, it's finding these early entry points to initiate this like mechanotransduction, to start initiating healing, to start, exciting these like proliferated cells within, that membrane in a positive way. That's not so threatening to the system.
Yeah, I mean, Katie Dabrowski said it best, in my opinion, right? We find our entry point, we calm things down, we build it back up, and then we clear people and they go on their way. It's
Yeah.
as simple as that sometimes.
Right. For sure. For sure.
Jeremy, I feel like we've covered a lot of different ground relating to rehab principles and considerations and different things in your own kind of background from an injury management standpoint. Is there anything that we missed or anything else you wanted to touch on today?
I think just the only thing I want to touch base on is highlighting the complexity of tendinopathy, just from based off of my own injuries. Um, I think tendinopathy is still, again, what I mentioned earlier, super oversimplified. Um, and I think based off that, we have to, as clinicians, as strength coaches, or anyone who's working with just athletes or patients, we have to understand or continue to understand the whole injury mechanism or physiology better, um, to start prescribing better exercises.
You mean to tell me that quad sets and straight leg raises alone aren't gonna cut it?
Probably not. I mean, again, there's a time and place for that for sure, but uh,
Yeah.
it's a huge continuum of um, trying to understand why things don't work all the time. And a lot of what I understood or understand right now about the pathophysiology of tendinopathy, um, is from actually a doctor of veterinary medicine, Stephen Arnosky. I think he's out of Michigan State, doing a lot of just tendon research for a lot of like orthopedic uh, physicians. He has a lot of good information on just understanding the pathophysiology of tendinopathy, because he quoted, it was like Anchorman, how like 60% of the time it works all the time kind of thing. And like that's true. It's like I'm pretty sure we've both had cases where chronic tendinopathy, like we throw everything at it, but nothing seems to stick or work, which is like the frustrating part. So with the increased treatment of like, all the Therex we can do and increased, you know, conservative treatments of like bio-orthologic stuff or shockwave, the PRPs, all that kind of stuff, like sure that could help, but you know, targeting our treatment to how we think they're on the continuum, that's super important to me.
Yeah, no, and I think that's a great point as well, is understanding that it even is a continuum.
Yeah.
Because I didn't feel like, and I don't want to bash schooling by any means, because I learned a lot from, my grad school and all that way, but I felt like that was a missing piece, is how injuries present along a continuum.
Yeah.
Whereas I felt like, out of school, it's like, okay, you get them, you diagnose them, and then it's phase 1 to 4. And it's
Right.
like, well, what happens when you never get past phase 1? Or what happens when you're
Yeah.
in phase 3 and you never get to 4?
Yeah.
Right. So there's and people come to you in different stages as well, right? Some people are in phase 3 and having issues. Some people haven't even touched phase 1 yet. So understanding that everything exists on a continuum, and understanding that, things can change at a moment's notice. I've seen that too often clinically, where one minute everyone is doing great, and then I get a text after the weekend and you know, someone pulled something like I would do and go off program and do something a little stupid and it just didn't go well. So it happens.
I mean, that's the key word. Things could change at a moment's notice. That's a testament to the complexity of tendinopathy. So it's, I mean, a common treatment is like the NSAIDs, right? Oh, I have tendinopathy. Let's take some ibuprofen. Um, when then a lot of times, if it's starting to become chronic, the NSAIDs don't work because there's so much stuff going on at that tendon level where there is this like they call it like cell metaplasia, where a bunch of I believe it's the tenocytes, they kind of turn into more like chondral kind of cells where it's more but like the consistency of cartilage, where that doesn't help. There's a collagen like deformation in the fibers from like a micro standpoint, where there's when there's trying to like cell proliferation within that network that's already disorganized, then that cell proliferation doesn't help because there's not enough macro trauma for actual inflammation. Like there's no inflammation there. It's like very micro inflammation where NSAIDs, I feel like, wouldn't even work. And with that, I mean, like the upregulation of all these like pro-inflammatory markers, again, that don't really catch the eye of the inflammatory response, doesn't work. So it's pretty much like a very rogue like process where that's where we're getting increased like nociception, where we're still not putting things in like the extracellular matrix into a position where it could start healing.
Yeah, definitely, definitely. And Jeremy, I feel like you're an absolute wealth of knowledge on this. And I know you played a role in the first fascial mechanics course there for Rude Rock, and I want to link to that. Where else can people find you at online? Are you an Instagram guy, or are you still like
Yeah.
MySpace generation or
You can find me on Instagram. I believe it's Jaspa _ Rude Rock _ ATC. And then you could find the Rude Rock link to that and all the rest of our coaches. Right now, we have the Fascial Mechanics for Sport course. Definitely recommend that. Not to mention there's NSCA CEUs for all the CSCS folks in the room. And then ruderockstrength.com.
awesome? We'll link to all of that in the description below. I'm shocked he didn't give like Chipper's Feet Finder account a shout out there.
No comment.
Oh man. Jeremy, I really appreciate your time today, man. Thank you so much for everything.
Yeah, thank you. This is fun, man.